Hi all. Today let's talk about something interesting, just like we had our previous lectures. So the topic, let it be a surprise. So you'll have to track the case or the topic of discussion based on the case that is given. Fine. So now let's move on with the case. So the case is this is a 5-day old male neonate. Okay, remember it's a 5-day old male. So the age of presentation is very important for any case that we are going to discuss. Fine, and this is born at term by normal vaginal delivery. Okay, and it was brought to NICU with complaints of poor feeding, repeated vomiting, lethargy, and jaundice. So I think you could recollect some similar presentation, some similar case in the series of lectures that we had before. Yeah, okay, we'll connect it later on. Let's move on. So the mother reported that the baby started having symptoms soon after initiation of breastfeeding. So this is one another important pointer. So two important pointers that you have to remember before moving ahead is that the age of presentation, which was this is actually in a 5-day old neonate, and symptoms of feeding difficulties, poor feeding, vomiting, lethargy, and hepatomegaly, which is basically ballooning of the abdomen, and then jaundice. All these things soon after the baby was put on breast milk. Fine. And on examination, the infant was hypotonic, icteric. Icteric again means it's jaundiced, and hepatomegaly was noticed. And there was also evidence of failure to thrive and mild hypoglycemia. Hypoglycemia, it's another pointer here. And moving on, laboratory investigations revealed elevated total and direct bilirubin, raised liver enzymes, metabolic acidosis, and reducing substances in presence in urine, but glucose is negative. Okay, so once again, so to summarize, this is a case of 5-day old neonate which presented with complaints of poor feeding, vomiting, and jaundice, and there were features of hepatomegaly as soon as the baby was put on breast milk. And in addition, laboratory evidences also revealed there was elevated liver enzyme, that it showed there's something wrong with liver, elevated liver enzymes and total and direct bilirubin. And in addition, the baby also had metabolic acidosis, and there was reducing substances in urine, but it was not glucose, it was something else. Fine. And in addition, there was also hypoglycemia and failure to thrive. Okay, what if I say you that to add on to this, the baby was evaluated some 2 weeks later, and the baby was found to have a cataract, a typical cataract. Okay, it's called an oil drop cataract. Or okay, and after some time the baby also developed features of septicemia, neonatal sepsis, and on culture it was found to be E. coli. Okay, sepsis due to E. coli. So now, putting everything together, can you guess what the culprit is? Yeah, it is something with regard to galactose metabolism. So now let's move on with the topic proper. So galactose, we have read about the carbohydrate chemistry. So there I told you about many epimers of glucose. So glucose has 3 epimers. So the C2 epimer of glucose is mannose, C3 epimer is allose, whereas C4 epimer is galactose. So what do you mean by an epimer? To recollect, so epimer is something which is structurally similar to the parent carbohydrate, but it just differs with regard to the orientation of H plus and OH minus at one particular position. So since galactose is a C4 epimer of glucose, there is difference in the orientation of H plus and OH minus at C4. Okay, so C4, so fourth epimer of glucose, and it is a constituent of lactose of milk sugar. It's not an essential nutrient, and the metabolism happens in liver. So this is the ring form structure of galactose. The straight chain form, I hope you all know how it is. Okay, so moving ahead. Now let's see the importance of galactose. So galactose is essential because that in turn gives you lactose. So how is this formed? There's something called UDP glucose. Okay, so this UDP glucose gets converted to UDP galactose. This shouldn't come here, this is actually here. Okay, so this gives you UDP galactose, and the enzyme here is epimerase, because these both are epimers, right? So now to the interconversion between two epimers is brought about by an enzyme called epimerase. This gives you UDP galactose, and this UDP galactose combines with another molecule of glucose and gives you lactose. The enzyme is lactose synthase. Fine, as simple as that. Lactose is derived from galactose, okay, by a series of reactions. Fine. So lactose synthesis requires galactose. Moving ahead, it is also required for synthesis of glycosaminoglycans. So recollecting from what you have learned earlier, what do you mean by glycosaminoglycans? So glycosaminoglycan, it is a combination of amino sugar and an acidic sugar. Okay, so what all amino sugars you know of are present in glycosaminoglycans? The amino sugars are, there are two amino sugars that you should know. One is glucosamine and the other one is galactosamine. Okay, so I hope you understood how galactose is important for glycosaminoglycan synthesis. And acidic sugars, if you could recollect, there were two. What were they? One was glucuronic acid and the other one was iduronic acid, right? So many combinations of these four give you different types of glycosaminoglycans. Like we have chondroitin sulfate, heparin sulfate, heparin, dermatin sulfate, and so on, right? So moving on, okay, so moving on to the next thing, which is cerebrosides. So cerebrosides are also something which is essential. So this is nothing but a combination of sphingosine and a fatty acid plus a ceramide. I'm sorry, sphingosine plus fatty acid is a ceramide. Okay, plus you have something called monosaccharide, right? So this monosaccharide can be glucose, it can be galactose, and depending upon which monosaccharide is present, it is named so. So we have something called glucocerebroside, we have something called galactocerebroside, right? So this is about cerebrosides. So it's also required for glycolipids, basically a combination of carbohydrates and lipids, and it's also required for synthesis of glycoproteins, combination of carbohydrates and proteins. So this is in short about the uses of galactose. So what a galactose is, what type of sugar it is, how it is different from glucose, and what are the compounds that we get out of galactose. So we get lactose, we get glycosaminoglycans, we get cerebrosides, glycolipids, and glycoproteins. Fine. So glycolipids, cerebrosides, all these things, they are essential for a growing brain. That's something that you have to know. So for myelination and for proper development of neurons, these compounds are like very essential. Fine. Moving ahead to the galactose metabolism. So galactose metabolism is a series of reactions, just like fructose metabolism. It's like it's very simple. So let's see how it is metabolized. Okay, so galactose, it has to begin with galactose. So galactose, what is the first reaction that takes place in glucose and fructose? So something which is common to every pathway. The first pathway is always catalyzed by a kinase. Okay, so this is galactokinase. So basically galactose gets phosphorylated, so you get galactose 1 phosphate. Okay, so this galactose 1 phosphate, sorry. So this galactose 1 phosphate essentially gets converted to glucose 1 phosphate. Okay, so this essentially gets converted to glucose 1 phosphate. So how does this thing happening? This is by an enzyme called GALT, that is galactose 1 phosphate uridyl transferase. Okay, so galactose 1 phosphate uridyl transferase, as the name says, it's an uridyl transferase. So something has to get converted to something, and that reaction happening here is we have UDP glucose. Okay, so this UDP glucose gets converted to UDP galactose. Okay, and now glucose is free, and this glucose comes here as glucose 1-phosphate. Understood? So galactose, the first reaction is catalyzed by the enzyme galactokinase that converts galactose into galactose 1-phosphate, and this galactose 1-phosphate gets converted to glucose 1-phosphate by the enzyme galactose 1-phosphate uridyl transferase. So this G stands for galactose and not glucose, remember that. And in this pathway we get glucose 1-phosphate. Where does this glucose come from? It comes from UDP glucose. So UDP glucose gets converted to UDP galactose. So this UDP galactose again has to get converted back to UDP glucose, right? So UDP glucose essentially gets recycled in this reaction, and this enzyme here is epimerase. Okay, so this is it. So like fructose metabolism, there should be enzyme deficiencies associated with the enzymes involved, right? Some inborn error of metabolism associated with the enzymes involved. So this galactokinase deficiency, this is not so, what to say, it's a benign condition. So this is called as, if this is deficient, it is called as non-classic galactosemia. Okay, galactosemia. Whereas if these both, so this is actually abbreviated as GALT. So this GALT deficiency or epimerase deficiency, this one here. Okay, so these both, if they are deficient, then it is said to be classic galactosemia. Okay, so just remember there are only three enzymes that you'll have to remember. One thing is the one which phosphorylase galactose, which is simply galactokinase. So galactose to galactose 1-phosphate by your galactokinase. If that enzyme is deficient, what you get is non-classic galactosemia, and galactose 1-phosphate has to get converted to glucose 1-phosphate, and this is by the enzyme galactose 1-phosphate uridyl transferase, which is simply called as GALT. And in this process, UDP glucose gets converted to UDP galactose, but this UDP glucose gets recycled back by the enzyme epimerase, and these two enzyme deficiencies results in what is called classic galactosemia. Fine. So I have okay, so this is another picture summarizing the same thing whatever I said. This is called as Lelloyer pathway. So galactose gets converted to galactose 1-phosphate, and this is by the enzyme galactokinase. And I forgot to say, this is a kinase reaction, so ATP gets converted to ADP. Okay, and the released phosphate is sequestered in the form of galactose 1-phosphate, and in the next step galactose gets converted to glucose. Okay, and that is by our GALT enzyme, and in this process UDP glucose gets converted to UDP galactose, and this is our epimerase. Fine. And then this glucose 1-phosphate then gets converted, or then enters into your glycolysis. Fine. So this is our the pathway that I described to you earlier. There is one another pathway which you should know, that is called as pyrophosphorylase pathway. Okay, so here galactose gets converted to galactose 1-phosphate by the same enzyme galactokinase, but the next step there it was catalyzed by GALT, right? So there were two enzymes which were essentially playing a role. They were contributing to that conversion of galactose 1-phosphate to what to say, UDP galactose basically. So this here is catalyzed by the enzyme galactose 1-phosphate pyrophosphorylase. Okay, so this is characterized by the enzyme galactose 1-phosphate pyrophosphorylase. But the problem with this particular enzyme is that this becomes active only after 4 years of age. So until 4 years of age, this pyrophosphorylase pathway is not active at all. So it's predominantly your Lelloyer pathway that is acting, and that is going to bring in energy for the baby. It's after 4 years that this pathway comes into play because of activation of this particular enzyme here, which is galactose 1-phosphate pyrophosphorylase. Fine. So moving ahead, as I told you earlier, galactokinase deficiency is considered benign, so it is otherwise called as non-classic galactosemia. And this GAL deficiency and epimerase deficiency, both these conditions result in what is called classic galactosemia. And what is this cataract here? So this is our classic oil drop cataract. Okay, that is seen in a case of galactosemia. Okay, let's see the causes later on in the coming slides. So moving ahead, with the condition called galactosemia. Remember, this is due to deficiency of enzyme galactose 1-phosphate uridyl transferase. Of course, epimerase deficiency can also cause classic galactosemia. And this is again an autosomal recessive condition, and the incidence being 1 in 35,000 live births. Age of onset being 1 to 2 weeks of life. That is very much important, because as soon as the baby is put on breast milk is rich in galactose, right? So baby starts developing all these symptoms because of deficiencies in enzymes involved in galactose metabolism. Fine. And then what is the substrate that is accumulating? Because galactose 1 phosphate uridyl transferase is deficient, the precursor substrate will accumulate. That is nothing but your galactose 1 phosphate that accumulates in liver. Okay, so this galactose 1 phosphate, I told you in the case that we discussed, the baby had features of hypoglycemia, if you could recollect. So that is again because it inhibits glycogen phosphorylase, causing hypoglycemia, and bilirubin conjugation is also reduced. So basically, there are certain features in galactosemia. I'll try to cover one by one. So just remember two clinical conditions, two clinical pictures or manifestations of the disease that I've dealt with in this slide. One is hypoglycemia, and the other one is bilirubin conjugation gets reduced, and that is one reason why the baby lands up getting jaundice. Fine. So moving ahead. So first thing is the baby will have enlargement of liver. Of course, metabolism is happening in liver. So if for some enzyme is deficient, the substrate has to accumulate. Accumulation happens within the site where it gets metabolized. And in this case, it is your liver. Okay, because of enlargement and injury to the hepatocytes, there is going to be jaundice and mental retardation. Can you guess the reason why mental retardation occurs in this condition? I told you earlier that galactose is required for the formation of lactose, glycosaminoglycans, and then what else? Glycosaminoglycans and glycolipids, glycoproteins, and cerebrosides, and all those things. And most of these compounds are pretty much involved in the early brain development, like myelination and other processes involved in brain development. So since galactose is deficient, all these pathways or all these metabolites are also compromised, and hence the baby's brain development is impaired. Okay, so that results in mental retardation. Fine. And then galactose 1 phosphate, it deposits in the renal tubules. So it causes something like proximal RTA like picture. Okay, so proximal RTA like picture. So whenever there is proximal RTA, the proximal convoluted tubule is the area where your amino acids are reabsorbed. Okay, so whenever something goes wrong with your proximal renal tubules, your amino acids cannot be reabsorbed, so they get excreted in urine. So that's why there is generalized amino aciduria. Fine. So this galactose 1 phosphate, it not only affects the liver where it gets metabolized, but this galactose 1 phosphate also moves into the systemic circulation, finds its way into the kidneys, and in kidneys it's going to affect your proximal convoluted tubules, resulting in proximal RTA, and causes generalized amino aciduria. Amino acids are lost. Fine. And this galactose, so I told you, any sugar for that matter, on oxidation gives you acid, but on reduction gives you an alcohol, right? So galactose is getting reduced. Excess of galactose is there, so it gets reduced, forming dulcitol. Okay, dulcitol or galactitol. And this dulcitol or galactitol, it is osmotically active. Okay, so what happens is it just keeps on imbibing water, and that is one another reason why there is some mental mental retardation and other signs of CNS depression noticed in these babies, because they are osmotically active. They they engorge more water, and they swell. Okay, and they cause the cells to swell. Okay, so because cerebral edema occurs, again they'll have some CNS depressive symptoms and signs. And in addition, because they are present in lens also, within the lens, if they accumulate, if the presence of these dulcitol molecules, which are osmotically active, draws in more water, causes crystallization of the lens, the lens becomes crystallized because of these amorphous substances which imbibe more and more water. It causes a characteristic oil drop cataract. Okay, so this oil drop cataract occurs because of dulcitol or sorbitol. So this is it. So again, I told you galactose gets converted to galactitol or dulcitol, and the enzyme here is aldose reductase. Okay, so in this reaction, NADPH gets converted to NADP. This is something, if you want, if you want to know, it is well and good. Okay, so this is how a clear lens looks like, and this is how a lens clouded by cataract looks like. And here in this case, what happens, there's going to be more and more water that gets imbibed, that is going to cause the lens has to be clear, right? But because water is getting accumulated, it forms, it gets nucleated, and then there is cataract formation. Okay, that is it. Because yeah, you can see that there is retention of water, and because there's retention of water, there's going to be injury of lens protons. Fine. So to summarize, these are the clinical features of accumulation of galactose 1 phosphate. So galactose 1 phosphate accumulation causes hepatomegaly, and because of hepatomegaly, there is going to be jaundice. And one another reason why jaundice occurs, any idea? It's there in the coming slide, but I'd like to say it here. Um, so we know that there is something called yeah. So we know that there is something called glucuronic acid, right? So there is something called glucuronic acid, and this glucuronic acid is important for conjugation, right? So conjugation of bilirubin and all those things require something called glucuronic acid, and this glucuronic acid is formed from UDP glucose. Okay, so it's formed from UDP glucose. Since this UDP glucose restoration is affected in galactosemia, it can again contribute to jaundice. Okay, so hepatocyte insult or the hepatocytes are getting affected, and that is one reason why they get land up getting jaundice. And the other reason is conjugation is affected because glucuronic acid is not formed, because UDP glucose recycling is not happening effectively, and that's one another reason why they get jaundice. And tubular injury, because galactose 1 phosphate accumulates in the proximal renal tubules, causing proximal RTA like picture. That's going to cause generalized aminoaciduria. Fine. And hypoglycemia, because galactose 1 phosphate is an allosteric inhibitor of glycogen phosphorylase, and it inhibits glycogenolysis. And mental retardation, because the formation of glycolipids, glycoproteins, glycosaminoglycans, and cerebrocytes, all these things which are required for the normal brain development is not available, because the precursor galactose is not available, and hence precursor galactose is not metabolized, and hence they land up getting mental retardation. Fine. So these are the this is like a summary for all the clinical features. So this is the same thing which I said you. The other reason for jaundice is reduced recycling of UDP glucose. So that in turn gives you reduced glucuronic acid, and hence there is reduced conjugation and increase in unconjugated fraction of bilirubin. Right. So this is it. So galactosemia, the other clinical features include failure to thrive, vomiting, feeding difficulties, seizures, and coma. And remember one more thing, that there is classically they are prone to neonatal sepsis. Okay, so neonatal sepsis due to E. coli is more common in these babies. Fine. And for prenatal diagnosis, you can go in for collection of fetal cells by amniocentesis or cell-free DNA mutation analysis. Okay, so this is mutation analysis and enzyme analysis. So enzyme assay and mutation analysis is something like a gold standard for any inborn error of metabolism. And other investigations include demonstration of galactose 1 phosphate level in blood and decreased. So you can demonstrate that this particular analyte is increased in blood. So this is a typical case of galactosemia. And one more thing is decreased blood glucose level, hypoglycemia, galactosuria. So to demonstrate galactosemia, you can do music acid test. Okay, so music acid is nothing but it's a dicarboxylic acid. So it is galactosaccharic acid. Okay, music acid inherently means it's a dicarboxylic acid or galactosaccharic acid. Okay, so that thing. And urinary galactitol can be measured, and prenatal screening includes amniocentesis. Fine. So treatment consists of lactose-free diet or soy milk special diet. But how long do you advocate this lactose-free diet for babies? So you'll have to basically stop breastfeeding and go in for soy milk feeding for these babies. But how long should the baby be on soy milk? Until, if you remember, until 4 years of age. Why? Because post 4 years of age, the other pathway, the pyrophosphorylase pathway, gets activated. Okay, so it gets metabolized. Even though there is gal deficiency, this galactose 1 phosphate will not accumulate. It will get converted to UDP galactose by something called as galactose 1 phosphate pyrophosphorylase. Okay, that's that pyrophosphorylase pathway. So after 4 years, they can take in lactose rich food as well. Okay, so moving on to the other deficiency, which is galactokinase deficiency. Is it as what do I say, as cruel as your gal deficiency? No, this is otherwise called as non-classic galactosemia. So the yeah, the deficiency, the incidence is 1 in 40,000 live births. It's due to deficiency of galactokinase. So what is getting accumulated here? So the substrate getting accumulated is galactose. Okay, so galactose is relatively less toxic than galactose 1 phosphate. So symptoms are milder. So galactose 1 phosphate is not formed. So majority of the symptoms, one thing is hypoglycemia, mental retardation, aminoaciduria, and jaundice. So all these things were attributed to galactose 1 phosphate accumulation. But here it is not happening because what is accumulating is just galactose. Okay, so cataract is seen. So since galactose is there, this galactose gets reduced to form what is called dulcitol or galactitol, and that's going to cause cataract. So cataract is a prominent picture here. Apart from that, the baby will not have features of mental retardation, hepatomegaly, or aminoaciduria and all. So baby will be fine otherwise. Fine. So this is it. Thank you. So to summarize, we began with what galactose is. So galactose is the C4 epimer of glucose. It's also an aldose sugar, and it is metabolized predominantly in liver. So there are two pathways. One is this Leloir pathway, and in Leloir pathway, what happens is galactose gets converted to galactose 1 phosphate by galactokinase. Galactose 1 phosphate gets converted to glucose 1 phosphate by the enzyme galactose 1 phosphate. Galactose 1 phosphate uridyl transferase. So this is nothing but galt. So this alongside what happens is UDP glucose gets converted to UDP galactose, and this UDP galactose again recycles UDP glucose back, and the enzyme involved is epimerase. So these two enzymes, galt and epimerase deficiency, results in what is called your classic galactosemia, and the galactokinase deficiency results in what is called as non-classic galactosemia. Okay, and then coming to the features of classic galactosemia, the baby will have hypoglycemia. Why? Because glycogen phosphorylase is inhibited by galactose 1 phosphate, so hypoglycemia, and they'll be having hepatomegaly and jaundice. Jaundice, there were two reasons. One is liver damage. The other reason is glucuronic acid is not formed. Okay, and apart from that, the baby will have cataract. Reason for cataract is because it is osmotically active. It gets converted to galactose gets converted or gets reduced to form galactitol or dulcitol, which forms cataract. Apart from that, they'll have vomiting, lethargy, and yeah, one more thing, that is aminoaciduria because of a proximal RTA-like picture. Okay, aminoaciduria because of a proximal RTA-like picture, because galactose 1 phosphate goes and deposits in the renal tubules. Fine. And yeah, mental retardation again. So mental retardation happens because all the substances like what all glycolipids, glycoproteins, and cerebrosides and glycosaminoglycans, all these are not formed because of galactose deficiency. And yeah, apart from that, poor feeding, vomiting, lethargy, seizures, all those things, failure to thrive, and they are more prone to neonatal sepsis. Okay, so neonatal sepsis due to E. coli. Okay, sepsis due to E. coli is also very common in these patients. And galactokinase deficiency, the only manifestation that they'll have is cataract. Okay, so why is this relatively benign? Because the substance which is accumulating is galactose, in contrast to galactose 1 phosphate, which was accumulating in a case of classic galactosemia. Fine. So this is in short about this thing. And one more important point to differentiate galactose metabolism disorders versus a fructose metabolism disorder is the age of onset. So remember, in galactose related disorders, the age of onset is quite early. It occurs soon after birth, as soon as the baby is put on breastfeeding, okay, breast milk. Whereas in fructose, it is by 6 months of age. So signs and symptoms sets in after the baby is put on supplementary feeding. Okay, so this is about galactose metabolism. I hope you enjoyed the video. So keep revising, and all the very best. Thank you.